Bismillahirrahmanirrahim. Assalamu alaikum. I am Zunaira Anjum and my roll number is 3154 and my course is Biochemistry of Carbohydrates. I am from second semester and this presentation is submitted to Honorable Dr. Aruj Hamid. The topic given to my group for presentation is primary hyperoxaluria. Now, I will first of all discuss the definition of primary hyperoxaluria. Primary hyperoxaluria is a rare condition characterized by recurrent kidney and bladder stones. The condition often results in end-stage renal disease that is abbreviated as ESRD, which is a life-threatening condition that prevents the kidneys from filtering fluids and waste products from the body effectively. My topic in this presentation is treatment of primary hyperoxaluria. Treatment must be introduced at an early stage and it is aimed at decreasing urinary saturation of calcium oxalate by increasing fluid intake and using urinary crystallization inhibitors. There are different methods used for treatment of primary hyperoxaluria. I will discuss some of them that are diet, pyridoxine, surgical management of urolithiasis, oxalate degrading enzymes, and crystallization inhibitors. And the rest of the methods are discussed by my fellow. Now, going towards diet. The reduction of oxalate intake is not very useful in primary hyperoxaluria, given that the endogenous oxalate source remains. However, it may be more useful in cases of enteric hyperoxaluria. The foods richest in oxalates are nuts, plums, chocolate, tea, Coca-Cola, beetroot, strawberries, etc. Calcium intake must be restricted since intestinal oxalate absorption increases as a result of it. Excess intake of vitamin C must be avoided, particularly in dialysis patients since ascorbic acid may be metabolized directly to calcium oxalate. The next method for treatment of primary hyperoxaluria is pyridoxine. Pyridoxine, vitamin B6, is perhaps the only method capable of effectively reducing oxalate production, but it is only applicable to cases of primary hyperoxaluria type 1. Pyridoxal 5-phosphate is a form of vitamin B6 that acts as an AGT cofactor, increasing transmission of glyoxylate oxalate precursor to glycine. Now, moving towards next topic for next method of treatment, that is surgical management of urolithiasis. Management of lithiasis in primary hyperoxaluria involves the normal concomitant presence of nephrocalcinosis. Treatment with lithotripsy involves the risk of applying shock waves to areas of nephrocalcinosis. As such, endoluminal endoscopic management is usually the treatment of choice, while open surgery is exceptional in this field. My next method of treatment is oxalate degrading enzyme. Although mammals cannot metabolize oxalate, other living beings have enzymes such as oxalate oxidase and oxalate decarboxylase, which are capable of degrading it, and they may provide a new solution for preventing the accumulation of oxalate in primary hyperoxaluria. In this regard, intestinal colonization with Oxalobacter formigenes, a bacteria that metabolizes oxalate, has shown promising results in rat models with primary hyperoxaluria and in some pilot students on patients. For patients with intestinal flora disorders, the use of probiotics, that is, food with living microorganisms added that remains active in the intestine, may be beneficial. These bacteria use intestinal oxalate as a source of energy and prevent their absorption. A combination of lactic acid producing lactobacilli has been used in patients with enteric hyperoxaluria, both inflammatory and secondary to intestinal resections, with a reduction in oxalaria and oxalocalcium saturation being demonstrated. In rat models with high oxalate diets, Oxalobacter formigenes supplements significantly reduce oxalaria. It has also been observed that Oxalobacter formigenes interacts with the colonic mucosa, favoring secretion of oxalate from the blood of the intestine. Next method of treatment is crystallization inhibitor. Crystallization inhibitor. The recommended crystallization inhibitors regimens are as follows. Potassium citrate is one of them. It forms complexes with calcium, decreasing calcium oxalate precipitation, and increases urinary primary hyperoxaluria. A daily potassium citrate dose of 0.1 to 0.15 grams per kg is recommended. In cases of renal failure, potassium citrate must be replaced by sodium citrate. Thiazides, in combination with potassium citrate, may be a useful supplement for reducing calciuria and increasing urinary volume. Next crystallization inhibitor is orthophosphate. It can be administered in doses of 30 to 40 milligram per kg per day. Magnesium. It is also a crystallization inhibitor. It is a known inhibitor of mineralization, and furthermore it reduces oxalate absorption when it is administered along with food. The recommended dose is 500 milligram per day. Thank you for so much for your time.